Women actually make 10 times more testosterone in their body than estrogen. So the amount of milligram of testosterone that is being made in your body is way more than estrogen. Why? Because we have those receptors in our brain, in our bone, in our muscle for our wellness and health. Of course, these hormones need to be balanced. A little bit high and low can cause symptoms. So one of the hormones that we are lacking in perimenopause to menopause is testosterone, that is not covered by insurance. It's kind of expensive. Physicians are not educated about it, and neither patients. And it can be really, really beneficial when it comes to health.
Hello, Thrivers. Welcome back to Thrive with Sharon podcast. I am Sharon Land, your host, as you know, and I'm also a licensed holistic psychotherapist, as well as best-selling author and internationally recognized mentor for high performance individuals. And I am so excited to continue this season. And today I have a absolutely beautiful new connection, and she's really made some really great difference to me in my life, but most importantly, I think has so much to share about women's health and hormone replacements, and just all of the great new, not so new information, but new to the US about how we can really optimize our health. So today I have Dr. ShadiZandieh, and she is a board certified internal and preventative medicine specialist with over 20 years of experience on the forefront of innovative treatments for anti-aging and women's healthcare, and her boundless passion. And I can second that she definitely has a lot of passion, which is great, and belief in personalized patient-centered approach to care for her to inspire her to open her new office, which is located in Martinsville, New Jersey, which is called Dr. Z Internal Medicine Clinic. And it is a beautiful, beautiful space. So I am so thrilled to have you here today. It's wonderful that we get to have this conversation in this way. And welcome to the show.
Thank you so much, Sharon, for having me. Hello to your audience, and I'm Dr. Zandieh. I'm the internal medicine and board certified hormone therapy physician, and recently opened my clinic in Martinsville. And thank you so much for your beautiful introduction. Let me just give you a very brief background of what brought me to functional medicine and hormone therapy. And I'm proud to say that was a personal reason. I am an internal medicine physician. I used to see only ICU patients and very sick patients on the floor. And what made me proud to the field of hormone therapy and functional medicine was my sister. I have an older sister. She's 4 years old, 4 years older than me, and she started having her menopause. It was almost 7 years ago. She had her menopause at age 41.
Wow.
It was a premature menopause, and it was a pretty rough path for her. And I was on every single step with her. She's not here. She's back in Iran. I'm Iranian. And she was suffering for like a whole couple of years, and I've been observing her suffering. And that brought me to the field that I had no clue. And I found that as a physician, who I was very proud of myself, that I did my training with great scores, and I did a few years of research in cardiology, oncology. I had zero knowledge about hormones, especially when it comes to menopause. And I didn't really have answer for a lot of questions that my sister was asking me. And I felt, oh, I'm missing a huge piece of knowledge. That's a gap in my knowledge that I need to fill it in. And I started self-educating. I found the training courses. I did my trainings back to back. It was actually during the COVID time that I did my main training with North American Menopause Society. And I did get my board certification of endocrinology with A4M, which is a functional medicine institute. And I'm so fascinated about the things that I learned over the past few years, and I applied it to my practice. And I would say hormone therapy is an amazing field that a lot of physicians are missing it in terms of knowing enough about it and applying the right knowledge to their practice. Unfortunately, what happened let me just start from here. I wanted to talk about menopause, which is a very underserved topic. Yes, even as a woman, you go to a crowd of women and talk about menopause, some people will get offended. They don't want to talk about it. It's like a taboo. It's like something you want to hide it. Unavoidable part of every woman's life. We all, with no exception, get menopause. And yet we don't talk about it enough.
No.
We don't vent out.
No, well, when we're going through it, or we're kind of on the front end of perimenopause and starting to experience some of the maybe not even so mild symptoms, but we don't even, for us here in this culture, like we're educated in like fifth grade, I think, on girls and women's health, right? So we're talking about things like period and menstruation, and they show us a sanitary pad and, talk to us about that kind of stuff. But there's never any further education and preparation for the constant evolution and changes of a woman's body, right? And
Sure.
so that's what you're talking about. So it's not even, it is, I think some people feel shame around it because they feel like there's something wrong with themselves because they're not feeling themselves anymore. They're also not performing in the same way. Aesthetically, they're seeing changes in their bodies, right? As well as their skin texture,
Absolutely.
that stuff, which I want to talk about all of those things, like how it does affect us. But so there is this shame, I think, because like culturally, and maybe not even culturally, but just across the board collectively, there is a huge emphasis on women's appearance and aesthetics and how they present themselves and all of that. And it's like in complete conflict and almost crisis when we start to go through the beginning stages of menopause. So, yeah, I think this is why I'm so excited about having this conversation, because I'm thinking about, you talk about root cause, right? And I'm sure that there are so many things on the prevention scale that we can do leading up to, perimenopause and menopause, right? So anything from like inappropriately used like birth control pills and, things where we're not addressing a lot of hormone imbalances in younger ages and that kind of stuff. But so tell me what your thoughts are then on like, so you started this discovery process and you really decided that, wow, there's a treasure trove of information and a huge amount of advocacy, as well as implementation of like appropriate use of hormone replacement therapy and the like. What would you say, like, if you were to go back, what were some of the first steps that you took into this that were starting to move the needle for you, and then also like conceptualizing for your sister and your patients at large?
Thank you so much for your question. And actually, let me just talk briefly about perimenopause, that you brought it up, and thank you. It's a very important matter, and a lot of women actually start experiencing similar symptoms of menopause or different symptoms than menopause symptoms that are called perimenopausal symptoms. And there are a variety of symptoms of musculoskeletal pain, brain fogs, like mood changes. Even some women start having depression episodes without even having any prior history or having any triggers in their life.
Yes.
And they don't feel themselves. And it can be started actually 5 to 10 years before starting menopause. So imagine if a woman getting menopause around age, let's say 50, they start having the symptoms from age 40. So it's a 10 years of misery that they go from this doctor to the other, and they just label them with the I would call them crazy diagnoses of fibromyalgia or depression or bipolar. And it's not that. It can be easily treated with the lower doses of progesterone, with a little bit of therapy and self awareness about the hormonal changes in their body and the changes they have to make to their diet and their exercise plan. They can dramatically improve those symptoms. So perimenopause also is a very important topic that needs to be discussed and talked about. But regarding the steps that I started, I would say I started this journey almost 7 years ago, and part of that actually happened during the COVID when I was getting some of the important course training. I was in the hospital, and I was in the front line with COVID patients, and I was the only physician driving in the highway from New Brunswick to Somerset Hospital, and I was seeing up to 40 patients. And as much as it was traumatizing and exhausting, it was a pretty good time for me to I would call it a turning point in my self-awareness. I was seeing only COVID patients because there was no other patients. We didn't have any cardiac patients. We didn't have any cancer patients. We didn't have any respiratory patients. It was only COVID. And surprisingly, I was seeing a lot of middle-aged patients that I was not having in my service, people in their 40s, 50s. I was seeing a lot of women, surprisingly. And then it made me think why I'm having, and these patients, they never been hospitalized, they never been sick. So why other part of the population are not getting this sick? What's going on here? And it made me think, I would say COVID was a turning point because I felt what we were doing as a physician, as a medical system, as a medical provider has failed. It's not working. So a virus, and I've been in the front line. I was a physician who was constantly in the hospital exposed to the virus. I didn't get sick. And I felt why there's so much difference between people to get the disease and severe form of it that makes them coming to the hospital and seek medical attention, and they get under a ventilator, and like what causes it. And of course, I'm sure there's so much data, some of it are right, some of it wrong when it comes to COVID. But I would say that was a turning point and brought me to the field that I have failed my patients. The path I'm going is not right. All I'm doing in the hospital, throwing some remdesivir, a little bit of oxygen, and I discharge them. And months later, they're still having symptoms. You're still feeling sick. So it's clear that I'm not getting to the root causes of it. And then over time, seeing more COVID patients and seeing them in an outpatient setting and the hospital, and seeing patients who got the COVID vaccine, different types of it, it made me find out that we are not getting to the root causes of this. These patients who are getting the severe form are clearly not healthy. And it brought me to the path of health, to focus on health. And when it comes to health, there's not lack of illness. There's so many people in their 40s and 50s. They don't have any illness. They don't have any heart disease or cancer or any like asthma or anything that you call it a disease. But they don't feel healthy. They are not healthy. They may not feel the same as they have the same health of years back.
Right. So do you think that part of that is because of the way that Western medicine is designed to measure health?
What do you mean by measure health?
So when you say that people are coming in and who are, they don't have heart disease, they don't have, all of these like different illnesses, but at the same time, they're not feeling good, right? So there's a disconnect between the tools of measurement that a lot of medicine might use to say, you're healthy or you're not healthy, right?
And 100%.
So
I am 100% agree with you, Sharon. And I would say, yes, you're right. There is, we do have the tools. We're not using them.
Yeah.
Because it's either very expensive or not affordable for a lot of patients, or it's not covered by insurance for the patients who have regular insurances.
Right. And kind of speaks into that piece where it's like, who's leading the show with regard to treatment, right? Is it the doctors who are in applying this medicine all day and like who are skilled and supervised and have all of those hours of face-to-face experience, or is it the insurance providers that are dictating? It's like there's a lot of insurance driven focus on what to test on, how to read the test, how to medicate, how to not medicate, like all of these things, right? So, I mean, that's a huge component of how this big old ship has been steered.
I would actually say, and thank you, you're very right. Actually, I would say both of them. I would say patients and I'm sorry, the physicians and medical system both are playing the role. We have our physicians who are graduated from medical school, from residency program, from their fellowship, and they are having a very tunnel vision, totally disease oriented, coming to the practice. And all they know is the guidelines that they are being taught during the medical school residency and fellowship.
Right.
And, it's a huge pool of data and information. It's impossible to keep up while you're seeing 20 something patients in the office or in the hospital every day.
Yeah.
So I would say both of it. We are designing our medical system to the point that physicians getting so busy, and we also train them totally disease oriented that they forget the root causes. Actually, we are starting with the root causes at the beginning of medical school. We read biology, we read pathophysiology, and we get to the root causes. We get at the cellular level and knowing what's going on in there. And then we become a clinician and we totally forget it. I think part of it is the system is kind of mandating the physician to go there. And just look at the hospitals. One physician seeing 20 something patients from 8 o'clock to 5 p.m. And it's like very sick patients. And we're like so focused on their disease. They're throwing medications here and there, IV. We make the patients stable. And while the patient is saying, oh, I'm not still feeling well, we discharge them because hospitals want the patient to be out. It's too much room and board, and it's too much money. So I would say insurances, our medical system, totally failing our patients. We don't have enough time to focus on our patients. And I will just tell you a very recent thing that happened to me, that I've been doing a very extensive blood work for my patient. A lot of like hormonal panels, extensive vitamin levels, and all the stuff that I need to dig into the patient's health and wellness. And I received a letter from one of the prestigious lab that I'm working with, is saying you should not send this panel for your patients. Per a state law, you might be penalized because a lot of insurances may not pay for this. And surprisingly, for I would say almost 90% of the patients I've been sending those labs, I've been getting abnormal and bad numbers that needed to be corrected and needed to be improved and needed even further workup and treatment. So I just throw that letter in the garbage, and I decided I'm going to pick another lab who could be helping the patient. I'm here to help the patient, not dealing with those ideas of as a physician, you can just do this number of the tests, and if you do more than this, insurance won't pay for it. And I think definitely health in U.S. needs to be at the center of attention. And when I'm talking about health, is a multi-aspect matter that goes to different things: our physical health, mental health, and I'm sure you are working with mental health, and the importance, and I think it should come into the center, and we need to talk about it. I think we started this panel to talk about hormone, but I just kind of deviated towards health.
But this is it's all part of it though, right? I mean, that's
exactly, absolutely.
Everything is so interrelated. And I think that, as providers, and I do have a lot of providers who are part of the podcast audience, but also as the patients, right? It's important for us to understand that everything is interrelated. And part of the thing with functional medicine is that it's integrative medicine. So it's It's
Mhm.
everything working together, everyone
Mhm.
working together, right? So we can't work in like a vacuum, right? And not think or care about what other people are doing or what they're receiving or not receiving outside of whatever that, lens is that they're there for you to be seen, right? Which it's so important. And I think that that's kind of what you're talking about with regard to like how our system is really not serving our patients well, right? Because we're not only are we maybe intuitively like wanting to go in that direction, but we're we're being threatened, right? To be penalized financially or otherwise. And so there's a lot of fear that's being bred into all of this as well, which I think is an important part to speak on. So I'm glad that you went there because I think it also, to me, I think it's important for people to understand, you are a 20-year experienced, physician and medical
Mhm.
doctor with, having seen countless amount of patients and worked in the systems in more than one particular hospital and system, right? And you also cross cultures, you cross, countries, right? And so you have a very good lens, and this is what where your feet are landing now. And
Mhm.
I think it's a very bold statement. Um, Yet I think it's a very important statement to be made, and have it be very clear. Like, clarity is kindness when it comes to our health, right? And when it
Absolutely.
comes to our vitality. So it's important to really be clear on those issues. Um, so let's talk a little bit more about, particularly women's hormonal health, and then, so taking us on the journey from perimenopause to menopause and then postmenopause, because I think there's a lot of myths out there about, if I've already been through menopause, then I can't receive hormone therapy, or if I'm X amount of years, whatever. So what would you say, like, if you were to be, if I were to say, okay, like, I'm gonna help to go and find the most ideal candidates to put in front of you so that you can collaboratively work together, right? Where you're able to do your job well and they're able to receive the best care. Who would you want to start working with? Like, who would be your ideal patient?
I don't look for ideal patients. I look
Okay.
for the patient who needs help. And I would call my patient population from women who are starting to experience perimenopause, which I will be shortly explaining the symptoms,
Mhm.
getting into the menopause and postmenopause. And I always tell my patients, do not wait for your menopause to come in. Seek the medical attention now.
Yeah.
Look into your baseline hormonal level. You don't need to wait for them to start your hormones. A lot of women actually get benefit from hormone therapy years before they start their menopause,
Yeah.
because they will have like a significant changes in their estrogen level, in their progesterone level. Everything will be going. Some women can get periods even a couple of years after their menopause. They are officially in menopause, their hormones are all confirming menopause state, but they're still getting their periods, and they may not know that they are eligible to get hormone therapy. So
Mm.
starting from perimenopause, symptoms can be, as I said, from top to bottom. Some patients start with, surprisingly, I had a patient that was like, of course, she was an exceptional case that I figured years after that happened, that she had a seizure at age 30. I'm sorry, that at age 45, that she was a lawyer, very healthy, very health oriented, and she just had a seizure out of the blue with no other condition.
Mm.
MRI, EEG, everything came back normal, and she was just looking for the underlying reason. And that's when I saw her, and like she couldn't find anything from her neurologist, she couldn't find anything from her internal medicine doctor. So she ended up in the functional medicine office that I was practicing, and she said, I don't know what's going on. They send me some anti-seizure medicine, and now you tell me what's going on with me. I don't want to take this Keppra. Why I'm being prescribed if my EEG is normal, my MRI is normal? Why did I have a seizure? So we digged into her blood works, and she was menopausal. She was already showing the menopausal levels of the hormones. I don't know how long it's been ongoing, but I assumed that it was probably the last year of her perimenopause, and then she started having the menopause because her symptoms was her levels were confirming it. So we started her on hormone. Her other symptoms, which were foggy brain and lack of energy and everything else, dramatically improved after a couple of months of being on hormones. So hormones can be started on perimenopause for all those symptoms. The other symptoms that I would like to talk is musculoskeletal. A lot of women in perimenopause, they say, I have constant shoulder pain. I have constant knee pain. I can't recover from my exercises as I used to. I have body ache, and they go and ran all this rheumatologic tests from ANA, RF, all the lupus panel, rheumatoid arthritis panel, all comes back negative, and the rheumatologist will just put a label as fibromyalgia, go home, get some opioid medication. That's not true. With a couple of pills of progesterone at night, those symptoms will be gone. A little bit of change in diet and adding some vitamins and magnesium can change those pains and discomfort in the muscles. So the perimenopause is a huge topic. Of course, we can't cover it in a few minutes, but I just wanted to just briefly mention the symptoms. Other symptoms patients can experience is irregular periods, having prolonged PMS, premenstrual syndrome, having intermittent abdominal pain, bloating, you name it, itching. It's one of the common symptoms. Patients start having random itching in their body, like their body gets itchy, the areas that never been itchy, like behind their neck or in their scalp or under their chin or their ankle. They say it's becoming so itchy that wakes me up. And these are all in literature that been correlated to perimenopause period. And with a little bit of hormones, or as I said, the changes in diet and vitamins can help with that. So now let's just go to menopause, which is my favorite topic. Of course, perimenopause is as important as menopause, but in perimenopause, we usually try to avoid like estrogen, because usually most of the patients have that estrogen. But during menopause, we are lacking all the hormones, and from estrogen, progesterone, and testosterone, that nobody talks about it. When it comes to testosterone, everybody thinks that, oh, testosterone is for men, but it's very, I mean, I would just give you this surprising number that women actually make 10 times more testosterone in their body than estrogen. So the amount of milligram of testosterone that is being made in your body is way more than estrogen. Why? Because we have those receptors in our brain, in our bone, in our muscle for our wellness and health. Of course, these hormones need to be balanced. A little bit high and low can cause symptoms. So one of the hormones that we are lacking in perimenopause to menopause is testosterone, that is not covered by insurance. It's kind of expensive. Physicians are not educated about it, and neither patients. And it can be really, really beneficial when it comes to health, multiple aspects of health, libido, wellness, muscle improvement, recovery from exercises, brain function. And of course, during menopause, we have different ways of applying the hormones. So it can be patch, cream. And I'm very excited to tell you about the way that I do in my office, which is pellet placement. And the pellet is a small extended release piece of hormone that is being manufactured in good compounding pharmacies, and we apply it underneath of the skin in the fat tissue. It's a small procedure, and that hormone can be released gradually over a few months. So you don't need to apply the patch or cream on a daily basis, and it will be gradually absorbed, and it gives a very good steady level of hormones. And I would say it's one of the things that my patients love it and I love it. And the reason is I get the steady level of hormones. It doesn't go up and down. I'm not worried about absorption, because usually when it goes to the fat tissue, it's pretty vascular. So it's being absorbed steadily. And I have a new way of placement. It's called Pelicom. It's a very nice, fine equipment that is minimally painful, minimally invasive. It's done pretty quickly over like few minutes, and patient will be out of office, coming back in 6 months for the next one. So That's just wanted to talk about also Palette and
Yeah.
Peloton that I am doing in my office, and I just recently added to my services.
Yeah.
And of course, there are other ways of hormone replacement that if you want to discuss it in future, I will be more than happy to discuss with your audience. But did I cover everything? So perimenopause, menopause, and did you have any other questions about postmenopause?
Yeah, I definitely want to ask about that. But first, I want to just dig into the testosterone and the pellet therapy, because I think that's
Sure.
really, I mean, actually, I think that's probably how I originally found you, because we had some sort of a contact in common who was representing the marketing of that particular
Oh, Peloton.
brand of Peloton, right?
Mm-hmm.
And I thought, well, it's really fascinating for women, right? Because I've heard
Mm-hmm.
about pellet therapy for men, and quite honestly, there's what I want to kind of broach, because obviously it would be great for us to just talk about the utopic aspect of it, right? You come into the office, and it's great, and you come back in 6 months. However, the thing that prevents people from actually going forward with pursuing pellets is there are a lot of not factual information. There's a lot of myths out there about like women and testosterone and being overdosed with testosterone, and that only men should be receiving pellets. And so can you speak into that a little bit, because I think that's really important. For me, I'm nowhere near as level and like in the passion factory as you are with regard to this, but like I'm very passionate about this, because I personally, I'm this is me. We're talking about me right now. These are all like asking for a friend and myself, but also like I think it's very important because women, I believe there's this aspect that women really aren't raised to believe that it's okay to feel great, right? That we really can feel vital. We can feel alive, and and no matter what age or stage we are. And testosterone, I do have friends that are great advocates of use of testosterone, and they say it's like the fountain of youth. It's really like incredible, right?
Yeah, it's true.
So, and I was
I
so
think that's a
resistant.
very right term for it.
I was resistant to taking it myself. I was like, I don't want to be all bulky and whatever. So, like, can you speak into some of the wives' tales that are told about testosterone in women, and especially with regard to pellets?
Sure, sure. So when it comes to hormones, my approach is start low, go slow. That's what I do because with
Mm-hmm.
hormones, I want to have the balanced level. I don't want to overdose. I don't want to underdose. So there's it's very individualized. Like I am not really fan of going to the variation that lab's giving to me. I have a patient who does great with a number of TSH from the thyroid panel, and I like the other patients that this number will be feeling really bad and will not be feeling well. So I think it's very individualized, but overall, I would like to have a moderate and balanced level of hormone in the body. So I always tell my patients, if you want to go, first of all, testosterone is a hormone that has been recognized in female body over 100 years ago. And there are data and there are literature that confirming that they found the same they were calling it a male hormone in female body. And they were thinking those females are not normal. I will share those information
Wow.
with you. I remember actually Dr. Pamela Smith, who is very well known in world of hormone. Actually, she showed me actually that literature that goes back to almost 100 years ago. It was published in a journal in England, and she showed us the first time testosterone actually was recognized in female body. And they were calling it an abnormal finding. So they thought that it's completely abnormal. Those patients who had that was abnormal. And then
Wow.
the more we advanced in medicine, we found no, that's part of female body. And it's actually pretty abundant in their body. Of course, the receptors are in different areas. The function is a little different to male. And the level should be definitely lower than what we have in male. But testosterone is absolutely crucial for women, the same as progesterone. You will be surprised to see that
Yeah.
male patients have progesterone in their body and actually helps them. They did a study in and I think it was in Norway, that they did a trial that they were because it's kind of a very anti-inflammatory, progesterone is very anti-inflammatory. They infused progesterone in male with stroke, and they were seeing way better results in them. For some reason, that study
Wow.
stopped because it was not funded, but they were infusing IV progesterone in post-stroke patients,
Wow.
and male and female, and they were getting great results. So that study I will share with you as well. So what I'm trying to say is testosterone is definitely a crucial hormone for female body. Of course, it needs to be dosed per need. Some patients may need lower dose. Some patients may need higher doses. We always check the level. There's some certain level that works for some patients, and that's why I do serial marking, the blood markers, to make sure that I have my patients in the right level, and then I will just have them on that same level. Some patients will do great when their levels is higher. Some patients are doing better when it's in the middle of the range. So when it comes to palate, I always want my patient to be on a patch or cream, not the patch. Unfortunately, with testosterone, we don't have any patch. It's just the cream that is being compounded in pharmacies. And based on the dose that they need for like few months to a year, then we'll decide what will be the dose that they get benefit when it comes to palate. And then I always start with the low dose. And meanwhile, if their dose is not enough, I add a little bit of cream to it. And then for their next dose, I know what the dose would be, and then I should be increasing it gradually. So, and when it comes to palate, Sharon, I would say palate been used in medicine over decades. We had many, many medications that been compounded and being inserted into the body, including the progesterone for patients who were getting severe dysmenorrhea and bleeding. We had pallets of chemotherapy. We had pallets of antibiotic medications. We still have pallets of antibiotic that is being inserted into the joints for people who are getting joint infection and osteomyelitis. So this been used in medicine for many, many years, and they are very well now. But when it comes to hormones, unfortunately, there's so much misinformation, and I would call misinformation and disinformation. And it's so difficult to fight it over. There wasn't a study came out in 2001. It was called Women's Health Initiative. I don't know if you heard about that study, but that study was a huge clinical trial that was done on women. It was almost 100,000 women. It was done on women from age around 60 to 75, almost 10 years postmenopause, and their average age was around 65. And they started them on high dose synthetic horsey estrogen and equinase estrogen and progestin. They put these patients on these hormones, and they were giving those synthetic hormones like candy to those patients, and they were like checking them every 6 months, and boom, in less than 4 years. Some data that was not properly corrected by the right team, it just leaked into the media, and they said, "Oh, it increases the risk of cancer in women."
Yeah.
And
Yeah.
all of a sudden, hormones stopped.
Yep.
So since then, which was almost 20 something years ago, we have a huge change in the world of hormone. We have new bioidentical hormones,
Yes.
hormones that are completely similar to the same identical hormone that our body makes physiologically.
So is that what bioidentical means? Can you explain that? Because I know the term, but I don't know that everybody understands what that means. The difference.
Sure. Bioidentical means that those hormones are exactly designed the same way that our body secreting the hormone, and the same molecule, the same formulation. So our body is designed to respond and accept those hormones that exactly similar. So their function will be the same thing. But if we are exposing our body to synthetic hormone, of course, horsey estrogen, it might be similar to human body, but it's not the same, right? So the molecules is slightly different. So over time, it's causing some bad function and side effects that we were seeing back then. Now what we have is exactly identical hormone, the same as we physiologically secrete in our body. And that's what is called bioidentical hormone. And it's completely different. It's not being, especially estrogen, is not being given orally. So you don't take any pills. It's only applied to the skin, or is being inserted as a pellet, or is some people get injectable. It's not very common. And the only thing that is being provided orally is progesterone. And the reason we don't give hormones anymore with the through the mouth is hormones can be absorbed in the stomach and get into the circulation of the, like a enterohepatic circulation, we call it, get into the liver, and they can turn into a bad carcinogen and cancer producing metabolite. So I always tell my patients, do not take any estrogen pills. It should be only applied topically, yes, or cream or vaginally. That's what I give. And the same as testosterone.
Okay. I think that's really important to discern the difference. And especially, you know, for people who are, at least I know for me, a lot of the patients that I work with, I see them suffering, and, you know, they talk about my hip is killing me. I've gone to the, you know, rheumatologist, I've gone to this person, I've gone to that person, and they say there's nothing. Maybe there's a little bit of, like, you know, a pre-arthritic condition or whatever, which is kind of standard for someone who's in their 50s, right? Who's been active all their life.
Exactly.
So I think it's so important to know that where we might think it's a mystery illness, there's nothing tangible specifically where we can say, like, if you're low in estrogen, then you're automatically going to have hip pain. But we can infer that if we're starting to feel aches and pains in our bodies, or we have some issues within our musculoskeletal system, right, and we're around that age, that we can start to take a look at things like hormones, where our levels are. And even, you know, I'm wondering the nuance. You've talked about that a little bit with, like, your pellet therapy, where it's like what's good for one isn't necessarily good for the other. So we have the ideal number that we want somebody to be at, but then we have the number that someone feels the most vital at, right? So that's the other part of the art of then you building that relationship with your patient, so that you can create the teamwork between you and the patient, so that you can help one another to meet the goals of you making sure that they're ideally optimizing their health and preventing certain things. So that's the next thing that before we wrap up for today. I know that there are so many reasons why we want to look to women to look towards hormone replacement therapy. And a lot of the things that we've talked about is like mitigating pain, right? And discomfort and inflammation and all of those things. However, there are some other very serious risks of having low estrogen and of not, having the proper hormones in our body. So can you speak into that a little bit? Because I know we've talked about that before, where you're just very concerned about overall
health. Yes.
Yeah,
absolutely. Because when it comes to menopause, there's this and fact that everybody thinks we are talking about hot flashes and night sweats. When we are talking about menopause, we're talking about lack of hormones that a female body had in the major portion of their life, and now it's been here, and all of a sudden over a few months it gets here, and we don't estrogen and progesterone are not only for our ovaries and uterus and breasts. They have receptors all over our body, starting from brain and affecting our brain function and mental function, going to our endovascular and cardiovascular, our heart, our lungs, our gut, our bone, muscle. Every part of our human body is having receptors of estrogen and progesterone. So when it comes to estrogen specifically, it's very important to know that one of the most important things that estrogen does is a lot of patients actually saying, oh, I didn't feel anything. I mean, or sometimes they come with a little bit of breakthrough bleeding, and that actually upsets them. I tell the most important reason that I would like to give you estrogen is it can help and prevent osteoporosis, and it's very important. Unfortunately, osteoporosis and osteopenia, and it means that the reduction in the bone density in women is one of the most common cause of illness in their older ages, and also cause of death in women. So when it comes to hormones, I give them not only for their hair and their appearance, the way their skin glowy. They were calling it feminine hormone. I call it actually health hormone, because a lot of women coming with menopause symptoms, the first thing they say, I have foggy brain. I can be distracted easily. I'm not focused like before. My mental function is getting affected. I'm not feeling healthy anymore. I don't have, and surprisingly, they are just being labeled as psychosomatic disorder, or depressed, or oh, you just found out to have bipolar disorder at age 50 something.
Yeah. There's a lot of medical
So
gaslighting that goes along with that.
absolutely. And you just balance their hormones and all those symptoms will be gone. And the other thing that I would definitely focus on that for bioidentical hormone replacement therapy, especially estrogen, is the bone health. Bone health is very important. Musculoskeletal symptoms are overwhelming during the menopause and postmenopause. I have a numerous patients coming with frozen shoulders. I have patients coming with chronic hip pain. I have patients coming with ankle pain, with the wrist pain, and we don't find anything. We check all those inflammatory markers and all those like rheumatology markers. We can't label them as any other like diagnosis that we already had in medicine. It's not them. And with the replacement of the hormones, they can be easily fixed, and their symptoms will be much improved over time.
Yeah. And I love the prevention aspect, and the osteopenia and osteoporosis is very significant and serious. And
Very.
if that can be prevented, then, I think that it's worth it to take a look. Is there
Absolutely.
an age or a time frame that's too late for a woman to receive hormone therapy? I have a patient who's going to be 66. So she's postmenopause. She actually had a very young start to menopause.
Oh.
Is there a window of time where it's too late to start hormone therapy?
Yes, because that's the problem. Unfortunately, we don't have enough data when it comes to late start of the treatment. The best time of the starting the bioidentical hormone is in like 5 to 10 years post-menopause.
Okay.
So I would have started in perimenopause for a lot of my patients from a very low dose, and we gradually increase the dose. But when it comes to older ages, it's very individualized. I have to look at each cases. It depends on their underlying condition. Are they suffering from any heart disease? Are they having any underlying condition? And those things, have they ever had any history of cancer, breast cancer, ovarian cancer? These are the things that will determine if that would be a safe start of hormone. And as I said, I think every single woman should have a chance of using some of the hormones. So there are always some substitute. If they can't get the estrogen, we can give them some DHEA. We can try some like a low dose progesterone. We can always add some other hormones to kind of, testosterone is safer for women, especially when it comes to older ages. So we can just skip the estrogen and give them some testosterone for their health and well-being. And gradually we can increase the dose, and we can apply estrogen even over time and see if they respond well, and monitoring them closely. I think hormones are safe, effective. It's the completely false information that hormone may cause cancer. Yes, like other stuff, they can have some side effects. Even Tylenol, that is in all the supermarkets and the pharmacy shelves, you can easily go and grab it without any prescription. Hormones also may have some side effects. That's why it needs to be done under supervision of a licensed physician, and should be done in the right and proper way. But I would call them as one of the safest and most effective medications in the history of medicine.
Yes, 100%. And I think that's a great place to land for our conversation today, because I think we really took a nice, detailed, but not, there's still so much more I'm sure to talk about, but
Of course,
with regard to this, but like a nice detailed drive around the landscape of, women's health from perimenopause all the way to postmenopause and beyond. And I think that the fact that we were able to address those things, I would love to have you come back, because I know there's, a whole topic we could talk about with regard to nutraceuticals and peptides and all of those things, right?
Absolutely. I
Like,
love to talk about them. Yeah,
oh,
peptides are my favorite.
so exciting. I know.
Yeah,
So
sure.
exciting. And really address those things. But Dr. Zandieh, I'm so grateful that you were able to come and talk with our community today, and to take your time out of your day, because I know you're super busy, to share all of this wisdom and knowledge with us. And I'm going to place your website so that people can find you. You're based out of New Jersey. What county are you in again? I forget the county.
I think it's Somerset County. I'm in Martinsville.
Somerset County. And do you see people out of state?
Yes, I do.
Okay, so
Yes, I do. I do have patients who are having televisit, and sometimes they should come at least one visit a year, or every 2 years after the first visit. But
yeah,
we can do a lot of televisit. Yes.
yeah. So they can come to the grand old state of New Jersey and visit, and then
Sure.
take a holiday, and then just plan to do that like once a year. So that's wonderful. It's good to hear. And so will people be able to reach you through your website if they have any questions?
Yes, yes. My phone
Okay.
number and my office address in there. They're always welcome to call. We have very friendly staff in the office.
Yes, you do.
And I have great passion for what I'm doing, and I'm sure that I can help a lot of patients through this path. That's my main goal. And it was a pleasure to be with you, Sharon. Thank you so much for this opportunity. And I hope that I was helpful for your audiences. That I'm always open to any questions they have. They can email me. My email is in my website. They can reach out to me through the phone. Actually, office phone is always diverted to my phone if nobody answers here. So
Okay.
I'm actually also available through the phone if anybody wants to talk to me. And as I said, it was a great pleasure. Thank you so much. And I'm open to have more conversation about more topics, and it would be great.
Oh, well, I'm thrilled that you were here, and welcome to the community now, because now there's just going to be more people that, we all get to love and help. And that's the beautiful part about this podcast, is I just really love bringing people like you into other people's vision, so that they can see what's possible for themselves, and that there are really fantastic doctors out there who are really doing the heavy lifting that like you're doing. And it's really great to see. So I'm grateful.
Thank you so much.
Yeah.
Thank you so much. And I hope you have a great night.
Thank you. All right, everyone.
Take care.
Please leave your comments and any questions that you have. And of course, we love engagement. So please let us know what you'd like to hear from Dr. Zandieh, or just from our podcast going forward. And until the next time, lots of peace and love to you.